Bismillahir Rahmanir Rahim. In the name of Allah. Our topic today will be endometrial hyperplasia basic overview. Assalamu alaikum. Good morning, good afternoon, good evening, everyone, everywhere. Hoping you are well and stay safe. Contents of our lecture today: introduction, risk factors for endometrial hyperplasia and uterine cancer, how to diagnose endometrial hyperplasia, treatment, fertility sparing treatment for endometrial hyperplasia, short notes, and take work message. I hope it will be beneficial for you. Endometrial cancer. Why we are speaking today about endometrial cancer? As you know, endometrial cancer is the second most common gynecological cancer among female worldwide. While in Europe, it is the most common gynecological malignancy. Endometrial cancer worldwide considered the second most common gynecological cancer after cervical cancer. In Western, it is the most common gynecological cancer. And of course, endometrial hyperplasia considered the precursors for endometrial cancer. So, prevention, early detection, proper management of endometrial hyperplasia will lead to decrease in the incidence of uterine cancer. So our topic today is about endometrial hyperplasia. As you see, according to World Health Organization 2020, endometrial cancers comes as number 6 among cancers which affect the female, and comes number 2 among gynecological cancers affecting female. The first cancer is breast cancer, followed by colorectal cancer, followed by lung cancer, followed by cervical cancer, followed by thyroid cancer, and uterine cancer come number 6, followed by the stomach cancer, followed by ovarian cancer, followed by liver cancer, and finally non-Hodgkin lymphoma. Worldwide, about 4,000 new cases in 2020 of endometrial cancer, 97,000 cases of deaths due to endometrial cancer in 2020. In United Kingdom, about 9,000 new cases in 2017, and in Ireland, 460 new cases every year for endometrial cancer. It is also important to mention that over 90% of the uterine cancers are endometrial cancer originating in the endometrium. Endometrial cancer classification. There are two types of endometrial cancer. Type 1, which is the most common type, responsible for 80% of all endometrial cancer, and type 2, less common than type 1, responsible for 20% of endometrial cancer. So, what is the criteria for type 1 endometrial cancer? It is associated with hyperestrogenism, associated with endometrial hyperplasia. So endometrial hyperplasia is considered precursors for this type of endometrial cancer. Patient usually perimenopausal. Estrogen and progesterone receptors are common finding. Usually endometrioid and mucinous subtypes, and usually have favorable prognosis. Endometrial cancer classification. There are two types of endometrial cancer. Type 1, which is the most common type, responsible for 80% of all endometrial cancer, and type 2, less common than type 1, responsible for 20% of endometrial cancer. Criteria of type 2 endometrial carcinoma. Type 2 is not related to hyperestrogenism. Usually atrophic endometrium. Affect postmenopausal patients, so affect older patients. Estrogen and progesterone receptors, uncommon to find estrogen and progesterone receptor. Usually serous or clear cell subtypes, aggressive with poor prognosis. So what is the definition of endometrial hyperplasia? Endometrial hyperplasia can be defined as irregular proliferation of endometrial glands with an increase in the gland to stroma ratio when compared with proliferative endometrium. Endometrial hyperplasia classification. How should endometrial hyperplasia be classified? Indeed, there are currently two systems of endometrial hyperplasia classification. The first one, the World Health Organization schema, WHO 1994, revised in 2014. And the second one is the endometrial intraepithelial neoplasma diagnostic schema, developed by the International Endometrial Collaborative Group in 2003. World Health Organization classification in 2014 was adopted by the Royal College of Obstetrician and Gynecologist Green Top Guideline. It stated that the revised 2014 World Health Organization classification is recommended. In this classification, endometrial hyperplasia was classified into two groups. Group 1, hyperplasia without atypia. Group 2, hyperplasia with atypia. As we mentioned before, there are two schema for classification of endometrial hyperplasia, World Health Organization schema 1994 revised in 2014, and the second schema is called EIN classification. EIN classification is the endometrial intraepithelial neoplasm diagnostic schema developed by the International Endometrial Collaborative Group in 2003 and adopted by the American College of Obstetricians and Gynecologists. In this schema, depending on pathological criteria, it divided the hyperplasia into 3 categories. Category 1, benign endometrial hyperplasia. Category 2, pre-malignant endometrial intraepithelial neoplasia. And category 3, malignant, which is endometrial adenocarcinoma, endometrioid type, well differentiated. In this slide, which was quoted from Up to Date, you can find the classifications of endometrial hyperplasia according to World Health Organization 2014 and World Health Organization 1994, and the EIN classification, and what is the difference between the 3 classifications for your kind care and attention. What is the risk of progression of untreated endometrial hyperplasia into uterine cancer? What is the risk of progression of endometrial hyperplasia if untreated into uterine cancer? If we talk the World Health Organization 1994 classification of endometrial hyperplasia, which classified endometrial hyperplasia into 4 types: simple endometrial hyperplasia without atypia, complex hyperplasia without atypia, simple endometrial hyperplasia with atypia, complex hyperplasia with atypia. We will find the risk as follows. The risk of progression of simple endometrial hyperplasia without atypia to endometrial cancer over 20 years is 1%. The risk of progression of the complex endometrial hyperplasia without atypia to endometrial cancer is 3% if left untreated over 20 years. The risk of progression of the simple endometrial hyperplasia with atypia to endometrial cancer within 20 years if left untreated is 10%. And the risk increase to 30% for complex endometrial hyperplasia with atypia if left untreated over 20 years. So the risk is 1% for simple endometrial hyperplasia without atypia, 3% for complex endometrial hyperplasia without atypia, 10% for simple endometrial hyperplasia with atypia, 30% complex endometrial hyperplasia with atypia. The risk of progression of endometrial hyperplasia if untreated into endometrial cancer according to World Health Organization classification 2014 will be as follows. The risk of progression of endometrial hyperplasia without atypia into endometrial cancer within 20 years is less than 5%. The risk of progression of endometrial hyperplasia with atypia over 4 years into endometrial cancer is 8%. The risk of progression of endometrial hyperplasia with atypia over 9 years is 12%. And the risk of progression of endometrial hyperplasia with atypia into endometrial cancer over 19 years will be 27%. So the risk for endometrial hyperplasia without atypia to be endometrial cancer over 20 years is less than 5%. while the risk for endometrial hyperplasia with atypia to be endometrial cancer if left untreated over 19 years will be 27%. The most common presentation of endometrial hyperplasia is abnormal uterine bleeding. Abnormal uterine bleeding. This includes heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on hormonal replacement therapy, and postmenopausal bleeding. Postmenopausal bleeding. What are the risk factors for endometrial hyperplasia and endometrial carcinoma? Risk factors for endometrial hyperplasia and endometrial cancer. Age. Indeed, age and obesity are the strongest risk factor for endometrial hyperplasia and endometrial cancer. Endometrial cancer usually diagnosed between the age of 50 to 65, but it is important to mention that 2 to 5% of endometrial cancer diagnosed at age less than 40. 85% of endometrial cancer diagnosed at age older than 55 years. In United States of America, the peak incidence for endometrial cancer between ages 60 and 70 years. In Ireland, the age of incidence between 50 and 64 years, while in UK, during the period of 2015 to 2017, incidence rates for uterine cancer are highest in female aged 75 to 79 years. Women under age 50 who develop endometrial cancer are often at risk because of chronic anovulation and/or obesity. The other risk factor is obesity. It is an important risk factor. There are 3 mechanisms through which obesity produces endometrial hyperplasia and endometrial cancer. The first mechanism, excessive estrogen exposure. The second mechanism, increased insulin resistance. The third mechanism is inflammation. Regarding the first mechanism, excessive estrogen exposure, as we know, adipose tissue contain enzymes, one called aromatase enzyme, which convert androstenedione to estrone. The second enzyme called 17B hydroxysteroid dehydrogenase, which convert testosterone to estradiol. Regarding the second mechanism, hyperinsulinemia, obesity is associated with increased insulin resistance and chronic hyperinsulinemia. Hyperinsulinemia leads to a decrease in sex hormone binding globulin, which increase the bioavailable fraction of estrogen. The third mechanism is inflammation. Pro-inflammatory cytokines was released from the adipose tissue, and this pro-inflammatory cytokines create an inflammatory environment which considered as risk factor for hyperplasia and endometrial carcinoma. What are the other risk factors for hyperplasia and endometrial cancer? Polycystic ovarian syndrome, early menarche, late menopause, nulliparity, and infertility. Still, we are discussing the risk factor for endometrial hyperplasia and endometrial cancer. Of this risk factor, the use of unopposed estrogen therapy, estrogen-secreting ovarian tumors looks like granulosa cell tumor. Diabetes mellitus also considered as risk factor for endometrial hyperplasia and endometrial cancer. And the genetic factor as risk factor Lynch syndrome, or what is called hereditary non-polyposis colorectal cancer syndrome. As you know, it is autosomal dominant hereditary cancer. Women with Lynch syndrome have a 40 to 60% risk of developing endometrial cancer, 40 to 60% lifetime risk of developing colon cancer, and about 12% lifetime risk of developing ovarian cancer. Cowden syndrome is a part of the PTEN hamartoma tumor syndrome, a group of disorders caused by mutation in the PTEN gene. Patient with Cowden syndrome has high risk of both benign and malignant tumors of the breast, thyroid, endometrium, colorectal, kidney, and skin tumors. Of the risk factor also for endometrial hyperplasia and endometrial cancer, the family history of ovarian cancer, uterine cancer, breast cancer, bowel cancer, and the prolonged use of tamoxifen. As you know, tamoxifen used as adjuvant treatment for the breast cancer. It is selective estrogen modulator, or SERM, has estrogenic effect in the endometrium in postmenopausal women. Tamoxifen as risk factor for endometrial hyperplasia and endometrial cancer is dose and duration dependent. So we discussed most common risk factor for endometrial hyperplasia and endometrial cancer. I hope we can predict and screen all the patients for this risk factor and modify the modifiable one, so decrease the risk of hyperplasia and the endometrial cancer. What diagnostic and surveillance methods are available for endometrial hyperplasia? We agreed that endometrial hyperplasia is a histological diagnosis, means we need histological examination of the endometrial tissue to diagnose endometrial hyperplasia. In our hand, there are diagnostic and surveillance methods include outpatient or office endometrial biopsy, pipal endometrial biopsy, blind dilatation and curettage in the theater with or without diagnostic hysteroscopy if hysteroscopy is available, hysteroscopic guided biopsy, either inpatient or outpatient, and transvaginal ultrasound for endometrial thickness and endometrial morphology. We will discuss each item in the following slides. Office biopsy or outpatient endometrial biopsy using pipal device. Outpatient endometrial biopsy is convenient and has high overall accuracy for diagnosis endometrial cancer. The sensitivity of office pipal endometrial biopsy for diagnosis of endometrial cancer, about 99.6% in postmenopausal women and 91% in premenopausal women. So the sensitivity in postmenopausal women higher than sensitivity in premenopausal women regarding diagnosis of endometrial cancer, and the sensitivity for diagnosis of atypical endometrial hyperplasia is 81%. It is important to mention that 5% of the sample taken by office Bible device are insufficient or no sample for diagnosis. Regarding specificity for Bible outpatient endometrial biopsy, it is high specificity, ranged between 98 to 100% for the diagnosis of endometrial cancer. Outpatient endometrial biopsy, as you know, doesn't require anesthesia, can be done as outpatient procedure. There is no cervical dilatation in most of the cases, and it is convenient, as we mentioned, to the patient. As you see in this slide, which is quoted from Up to Date, the false negative endometrial biopsy in women with endometrial cancer undergoing a hysterectomy, the false negative endometrial biopsy will decrease if the endometrial cancer affecting more than 50% of uterine cavity, and the false negative result of office biopsy will increase if the uterine cancer or endometrial cancer was focal and affecting 5% or less of endometrial cancer. So the more diffuse and the more spread of endometrial cancer to cover the uterine cavity, the more accurate result of office endometrial biopsy. What diagnostic and surveillance methods are available for endometrial hyperplasia? We agreed that endometrial hyperplasia is a histological diagnosis, means we need histological examination of the endometrial tissue to diagnose endometrial hyperplasia. In our hand, there are diagnostic and surveillance methods include outpatient or office endometrial biopsy, Bible endometrial biopsy, blind dilatation and curettage in the theater with or without diagnostic hysteroscopy if hysteroscopy is available, hysteroscopic guided biopsy, either inpatient or outpatient, and transvaginal ultrasound for endometrial thickness and endometrial morphology. We will discuss each item in the following slides. The second tool for diagnosis and surveillance of endometrial hyperplasia is blind dilatation and curettage D&C. Indeed, this part is not mentioned in the Royal College of Obstetrician and Gynecologist UK Green Top Guideline about the management of endometrial hyperplasia, but I want to mention the importance, the limitation of blind dilatation and curettage D&C, particularly in raw resources setting when there is no hysteroscope is available. The American College of Obstetrician and Gynecologist published in 2015 committee opinion about endometrial intraepithelial neoplasia, and also the Irish guideline about management of postmenopausal bleeding stated that in approximately 60% of D&C procedure, less than half of the uterine cavity is curated. Again, approximately 60% of D&C specimens sample less than one half of the uterine cavity. So there is considerable risk with blind dilatation and curettage to miss a focal lesion. The American College of Obstetricians and Gynecologists recommended that regarding tissue sampling, hysteroscopy, while not required, is recommended with directed D&C to include any discrete lesion as well as the background endometrium. This will provide the best opportunity to confirm the diagnosis of true pre-malignant endometrial lesion and exclude an associated endometrial carcinoma. So the ideal is to do hysteroscopy, endometrial biopsy will be directed by hysteroscopic directed biopsy, and do dilatation and curettage and D&C and take the background endometrium. So you will have hysteroscopic evaluation, you will have hysteroscopic guided biopsy from any focal lesion, and you will have background for all the endometrium with dilatation and curettage with D&C. So the risk to miss any lesion is less and less. But the question is there still a role for blind dilatation and curettage in low resources setting when there is no hysteroscope and there is no outpatient Bible device? The answer is yes. Still, there is a role for blind dilatation and curettage for surveillance of endometrial hyperplasia and endometrial cancer in low resources setting where there is no other tools for diagnosis. So, what are indications of blind dilatation and curettage in absence of hysteroscopic facilities? Indications are similar to the indication of hysteroscopy. So the indication include but not limited to when a patient is not able to tolerate an office endometrial biopsy due to pain or anxiety, after a non-diagnostic office biopsy in patients who are at risk of endometrial carcinoma, when transvaginal ultrasound suggests a suspicious mass or polyp which may not be adequately sampled by office biopsy, after benign histology in office biopsy in patients who have persistent abnormal uterine bleeding, when there is insufficient tissue for analysis on office biopsy, when cervical stenosis prevents the completion of an office biopsy. Also, when a concomitant operative procedure such as laparoscopy is deemed necessary. It was example when the blind dilatation and curettage is needed. Again, dilatation and curettage usually require general anesthesia in an inpatient setting, and this is also one of the drawbacks. What diagnostic and surveillance methods are available for endometrial hyperplasia? We agreed that endometrial hyperplasia is a histological diagnosis, means we need histological examination of the endometrial tissue to diagnose endometrial hyperplasia. In our hand, there are diagnostic and surveillance methods include outpatient or office endometrial biopsy, pupil endometrial biopsy, blind dilatation and curettage in the theater with or without diagnostic hysteroscopy if hysteroscopy is available, hysteroscopic guided biopsy, either inpatient or outpatient, and transvaginal ultrasound for endometrial thickness and endometrial morphology. We will discuss each item in the following slides. The third tool for diagnosis and surveillance of endometrial hyperplasia and endometrial cancer is hysteroscopy and hysteroscopic guided biopsy. The Royal College of Obstetricians and Gynecologists Green Top Guideline Endometrial Hyperplasia stated that diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample, especially where outpatient sampling fails or it is non-diagnostic. Direct visualization and the biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. It is important to mention that hysteroscopy can be outpatient hysteroscopy or office hysteroscopy without anesthesia, can be inpatient hysteroscopy with anesthesia. Hysteroscopy per se is not a replacement for dilatation and curettage and thick sample because it can also miss endometrial cancer. So again, what is the indication of hysteroscopy and hysteroscopic guided endometrial biopsy? The same as we mentioned before, when a patient is not able to tolerate an office endometrial biopsy due to pain or anxiety. After a non-diagnostic office biopsy in patients who are at high risk of endometrial carcinoma. When transvaginal ultrasound suggests a suspicious mass or polyp which may not be adequately sampled by office biopsy. After benign histology on office biopsy in patients who have persistent abnormal uterine bleeding. So the clinical in this patient is important in spite the office endometrial biopsy come negative, but still there is bleeding, so it is still for need for further evaluation. When there is insufficient tissue for analysis on office biopsy, when cervical stenosis prevents the completion of an office biopsy, when a concomitant operative procedure such as laparoscopy is deemed necessary. Regarding the hysteroscopy, there is some concern about the risk of tumor dissemination. As you know, during hysteroscopy, we are using distension media, for example, the saline, and the questions if there is any malignant cells. This pressure, the pressure of this fluid can disseminate the malignant cells to the peritoneal cavity. Although hysteroscopy seems to be associated with a higher rate of positive peritoneal cytology, it seems not to have a negative impact on the survival rate. It seems not to have a negative impact on survival rate. Further study is needed to clarify the clinical impact of tumor cell dissemination. So further study is needed to clarify the clinical impact of tumor cell dissemination, but till now it seems not to have a negative impact on survival rate. What diagnostic and surveillance methods are available for endometrial hyperplasia? We agreed that endometrial hyperplasia is a histological diagnosis, means we need histological examination of the endometrial tissue to diagnose endometrial hyperplasia. In our hand, there are diagnostic and surveillance methods include outpatient or office endometrial biopsy, pupil endometrial biopsy, blind dilatation and curettage in the theater with or without diagnostic hysteroscopy if hysteroscopy is available, hysteroscopic guided biopsy, either inpatient or outpatient, and transvaginal ultrasound for endometrial thickness and endometrial morphology. We will discuss each item in the following slides. The fourth tool for surveillance and screening of endometrial hyperplasia and endometrial cancer is the transvaginal ultrasound. Indeed, in this part, I will mention the American College of Obstetrician and Gynecologist, the British Obstetrician and Gynecologist, and the Irish Obstetrician and Gynecologist guidelines regarding the use of ultrasound. Transvaginal ultrasound in postmenopausal bleeding. Transvaginal ultrasound in postmenopausal bleeding committee opinion mentioned that by American College of Obstetrician. Transvaginal ultrasound is appropriate for an initial evaluation of postmenopausal patient. So transvaginal ultrasound is appropriate for initial evaluation of postmenopausal patient. In America, if endometrial thickness is equal to or less than 4 mm, 99% negative predictive value, so the risk of malignancy is less than 1%. If endometrial thickness is 4 mm or less, according to American College of Obstetrician and Gynecologist. But the British mentioned less than 4 mm. The American less than or equal 4 mm, and the British mentioned less than 4 mm, not equal to 4 mm, less than 4 mm. Transvaginal ultrasound is a reasonable initial alternative to endometrial sample. It is initial and alternative. It helps us to triage this lady need further evaluation, or we can stop and follow clinically at this time or at this point. Can be useful in the triage of women in whom office endometrial sampling was performed, but tissue was insufficient for diagnosis. Asymptomatic postmenopausal women with endometrial thickness more than 4 mm tailor her plan of care. So in asymptomatic postmenopausal women who diagnosed with thick endometrium more than 4 mm but without bleeding, every woman will have a tailored plan according to her risk factor for malignancy. Endometrial thickness cutoff value. Indeed, when we are using transvaginal ultrasound for evaluation of endometrium, we evaluate two things. The first, the morphology of endometrium, and the second thing, endometrial thickness. Any abnormal feature in the endometrial morphology will require further investigation regardless of endometrial thickness. So, When we are speaking about endometrial thickness cutoff, we assume that the endometrial morphology is normal. It is very important. The second thing I mentioned here, the cutoff value for endometrial thickness according to the Irish guideline, American guideline, British guideline, and the British studies. In my slide, I mentioned the cutoff value below which the risk of malignancy is less than 1%, and above it, we need further investigation. So you will have a look for this value, and the cutoff value will be more than what I mentioned. I will start with the Irish guideline. The Irish guideline mentioned that in postmenopausal women not in HRT or postmenopausal women which didn't take HRT for 1 year or more, or postmenopausal woman on continuous combined HRT, the endometrial thickness, if equal to 3 mm or less, the risk of malignancy is less than 1%. But if it is more than 3 mm, further investigation is needed. So this is the endometrial thickness cutoff in these leads. Irish guideline mentioned that in women, postmenopausal women on sequential combined HRT, if the endometrial thickness equal to or less than 5 mm, risk of malignancy is less than 1%. Above 5 mm, start investigation. American College guideline mentioned that in postmenopausal women not in HRT, if endometrial thickness is 4 mm or less, risk of malignancy is less than 1%. More than 4 mm, start investigation. So the cutoff value here is more than 4 mm. What about the British guideline? The British guideline recommend if endometrial thickness is 4 mm or more, in postmenopausal women not in HRT, start investigation. This is the cutoff value. This is the cutoff value if endometrial thickness is 4 mm or more. Start the investigation. If endometrial thickness is less than 4 mm, according to the British guideline, the risk of malignancy less than 1%. What is the difference between British and the American guideline? Observe that in American guideline they stated of the endometrial thickness equal to or less than 4 mm, the risk of malignancy less than 1%. But the British mentioned if the endometrial thickness is less than, they didn't mention equal to, they mentioned less than 4 mm, the risk of malignancy is less than 1%. In some British studies, not guideline, but there is some papers I will put at the end of the lecture, they stated that if women on sequential combined HRT, if the endometrial thickness is less than 7 mm, the risk of malignancy is less than 1%. And they stated that if the women on continuous combined HRT, and the endometrial thickness cutoff value came less than 5 mm, the risk of malignancy is less than 1%. Again, it is not the British guideline, but it is the British studies. What is the role of endometrial thickness cutoff value in premenopausal patients? In premenopausal, not postmenopausal patient, what is the cutoff value for endometrial thickness? The role of ultrasound in premenopausal women is restricted to identifying structural abnormalities, as there seems to be an overlap between normal endometrial thickness and that caused by endometrial disease. In women with polycystic ovarian disease or polycystic ovarian syndrome with amenorrhea, the Royal College of Obstetrician and Gynecologist guidance supports the conclusion that endometrial thickness less than 7 mm as a cutoff value endometrial hyperplasia is unlikely. Again, in women with polycystic ovarian disease with amenorrhea, the Royal College of Obstetrician and Gynecologist guidance supports the conclusion that if endometrial thickness less than 7 mm as a cutoff value, endometrial hyperplasia is unlikely. In this slide, we can see the threshold of endometrial thickness on transvaginal ultrasound and the equivalent fraction of missed diagnosis in simple form. The lower the threshold for endometrial thickness cutoff value was taken, the unlikely to miss diagnosis, but the more patient to be investigated. Endometrial thickness measurement. It is conventional to measure the double thickness measurement of both endometrial surface at the thickest point in the mid-sagittal view. It is convenient to measure the double thickness measurement of both endometrial surface at the thickest point in mid-sagittal view. If there is fluid in the cavity separating the two layers of endometrium, then the layers are measured individually and collected together. Example of endometrial morphology and thickness. Endometrial morphology and thickness. It is important to mention that even if the patient had transvaginal ultrasound and came with endometrial thickness 3 mm or less, but still she is suffering from persistent or recurrent uterine bleeding, this patient still need for further evaluation for endometrial pathology. Why? Because of the false negative result of endometrial thickness by transvaginal ultrasound. The second thing, the type 2 endometrial cancer, which can occur in atrophic endometrium. So the clinical manifestations and the clinical scenario must guide you for further evaluation rather than depending on single tool for surveillance or for diagnosis. So remember, the clinical presentation is very important. What is the role of ultrasound in postmenopausal patient on HRT? American College Guideline mentioned that in postmenopausal bleeding with HRT, transvaginal ultrasound doesn't appear to be a useful screening tool. and we need to evaluate the endometrium by endometrial biopsy. American College of Obstetrician and Gynecologists mentioned that in postmenopausal women with HRT, transvaginal ultrasound doesn't appear to be a useful screening tool. The Irish guideline mentioned regarding postmenopausal bleeding in women using HRT. In women on sequential combined HRT, the probability of endometrial pathology is reduced in the presence of an endometrial thickness of 5 mm or less. In women on sequential combined HRT, the probability of endometrial pathology is reduced in the presence of endometrial thickness of 5 mm or less, according to the Irish guideline. In some British studies, not guideline, stated that in women on sequential combined HRT, the probability of endometrial pathology is reduced in the presence of an endometrial thickness of less than 7 mm. In women on sequential combined HRT, the probability of endometrial pathology is reduced in the presence of an endometrial thickness of less than 7 mm and less than 5 mm for continuous combined HRT, and less than 5 mm for continuous combined HRT. The reference for this study I will put at the end of the slide, and it is available in front of your kind care. Again, this is summary for the cutoff value for endometrial thickness with normal morphology for your kind review. The question now about women on tamoxifen. As we know, tamoxifen is used for adjuvant treatment for breast cancer, can be used for long time. So how we can follow up women on tamoxifen? The American College of Obstetrician and Gynecologist Committee opinion stated that in postmenopausal women, no role for baseline ultrasound endometrial thickness assessment. So there is no role for endometrial thickness assessment with ultrasound in women with tamoxifen. But the ultrasound can play a role in pre-treatment evaluation ruling out uterine polyps. Ultrasound can play a role in the pre-treatment to exclude or confirm uterine polyps. Endometrial biopsy, if any form of the bleeding, so women with tamoxifen, postmenopausal women with tamoxifen with bleeding or abnormal discharge, endometrial biopsy is the first step for evaluation endometrial pathology. In premenopausal, not postmenopausal, in premenopausal women, biopsy depends on the risk factors. So we need to tailor the further investigation in premenopausal women according to her risk factor. Algorithm for management of endometrial hyperplasia from the Green Top Guideline, Royal College of Obstetrician and Gynecologist, management of endometrial hyperplasia. Algorithm for the management of endometrial hyperplasia according to Royal College of Obstetrician and Gynecologist. According to WHO 2014, endometrial hyperplasia is divided into two main groups. Endometrial hyperplasia without atypia and endometrial hyperplasia with atypia. What is the initial management of endometrial hyperplasia without atypia? The initial management of endometrial hyperplasia without atypia include patient counseling, address risk factors, observation, progesterone, local or oral. Regarding the patient counseling, women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, and that the majority of cases of endometrial hyperplasia without atypia will regress spontaneously during follow-up. What about address risk factors? Reversible risk factors such as obesity, the use of HRT, anovulation due to polycystic ovarian disease, or even ongoing tamoxifen treatment should be identified and addressed if possible. For example, obesity, optimizing body weight, anovulation due to polycystic ovarian disease, management of polycystic ovarian disease according to the guideline to restore ovulation. Ongoing tamoxifen treatment should be reviewed in conjunction with the woman's oncologist, and we will try, if possible, to modify and address these risk factors. Observation. Observation alone with follow-up the endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. However, women should be informed that treatment with progesterone has a higher disease regression rate compared with observation alone. So observation alone can be a reasonable option, but the rate of regression in observation alone is less than if we use progesterone. What about progesterone? Progesterone treatment is indicated in women who fail to regress following observation alone and in symptomatic women with abnormal uterine bleeding. In this situation, we must start with progesterone as first line management. Okay, what about the progesterone? Both continuous oral and local levonorgestrel releasing intrauterine system or merinacoil progesterones are effective in achieving regression of endometrial hyperplasia without atypia. Both continuous use of either merinacoil or oral progesterone is effective in achieving regression of endometrial hyperplasia without atypia. The levonorgestrel intrauterine system or merinacoil should be the first line medical treatment because compared with oral progesterone, it has a higher disease regression rate with a more favorable bleeding profile and associated with fewer adverse effects. So the local progesterone is more preferred than oral one. Oral progesterone, it must be continuous. So continuous progesterone should be used either in the form of medroxyprogesterone 10 to 20 mg per day or norepinephrine 10 to 15 mg per day for women who decline the levonorgestrel intrauterine system or merinacoil. Cyclic progesterone shouldn't be used. Don't be used the progesterone in cyclical form. It must be continuous because the cyclic form is associated with less effective in inducing regression of endometrial hyperplasia without atypia compared with the continuous oral progesterone or merinacoil. If the patient with endometrial hyperplasia without atypia under Went this medical medications or conservative treatment, we must follow up with endometrial biopsy. And the first endometrial biopsy will be taken after 6 months from initiation of the treatment. The follow-up interval should be customized to each woman, taking into account baseline risk factors, associated symptoms, and response to the treatment. What about the initial management of endometrial hyperplasia with atypia? The initial management for endometrial hyperplasia with atypia. Indeed, women with atypical hyperplasia should undergo a total hysterectomy because of the risk of underlying malignancy or progression to a cancer. A laparoscopic approach to total hysterectomy is preferable to an abdominal approach as it is associated with shorter hospital stay, less post-operative pain, and quicker recovery. There is no benefit from intraoperative frozen section analysis of the endometrium or routine lymphadenectomy. Postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. Again, postmenopausal women with atypical hyperplasia should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. But for premenopausal women, the decision to remove the ovaries should be individualized. So, in postmenopausal, bilateral salpingo-oophorectomy should be offered. In premenopausal, tailor the decision. However, this is in premenopausal, bilateral salpingectomy should be considered as this may result in reduction in the risk of a future ovarian malignancy. Endometrial ablation is not recommended because complete and persistent endometrial destruction can't be ensured, and the intrauterine adhesion formation may prevent endometrial histological surveillance. So endometrial ablation is not recommended. But if the woman was contraindicated for hysterectomy plus or minus bilateral salpingo-oophorectomy, or if the woman with endometrial hyperplasia with atypia opt for or want pregnancy or fertility required, what is the option? The option in this case, we can try address the risk factor plus progesterone, either levonorgestrel intrauterine releasing system or oral progesterone. And the patient must undergo meticulous surveillance with endometrial biopsy taken 3 months after the initiation of treatment. And again, the follow-up interval should be customized to each woman, taking into account the baseline risk factor, associated symptoms, and response to treatment. After we start the medical management for the lady with endometrial hyperplasia without atypia and take the biopsy after 6 months, or if lady with endometrial hyperplasia with atypia but declined or contraindicated total abdominal hysterectomy, bilateral salpingo-oophorectomy, and we offer the hair progesterone treatment and take sample after 3 months, the first endometrial sample will come to inform us about 3 things. Either there is regression or persistence of the disease, or there is progression. What is the definition of regression? What is the definition of persistence? What is the definition of progression? What is the definition of relapse? I will mention the definition so we can follow up the algorithm. Regression means non-hyperplastic or non-malignant endometrial sample or non-diagnostic endometrial sample from an appropriately placed endometrial sample device. What is the definition of persistence? No regression or progression of initial endometrial hyperplasia without atypia after 3 or more months. Progression means development of atypical hyperplasia or endometrial cancer. Relapse means recurrence of endometrial hyperplasia with atypia or endometrial hyperplasia without atypia after 1 or more negative endometrial biopsy results. So this definition will be used during the algorithm. So if the first sample came as regression, what is the plan after that? We need to review our medical treatment. So treatment with oral progesterone or levonorgestrel releasing intrauterine releasing device should be for a minimum of 6 months in order to induce histological regression of endometrial hyperplasia without atypia. So initially, the management at least must be for 6 months in case of endometrial hyperplasia without atypia to ensure there is regression of the hyperplasia. If the patient was treated with merinocoil or levonorgestrel intrauterine device and histopathology after 6 months come regression, and if the adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the levonorgestrel intrauterine system for up to 5 years, and this reduces the risk of relapse. It will decrease the risk of relapse, especially if the levonorgestrel intrauterine system treat abnormal uterine bleeding symptoms, can alleviate the abnormal bleeding uterine symptoms, If women used oral progesterone for 6 months and the result come negative, we can stop the progesterone, but we need follow-up with endometrial sample. If still persistent bleeding in spite of medical management, total abdominal hysterectomy plus or minus bilateral salpingo-oophorectomy is one of the surgical management and must be offered. How we can follow up this lady, the lady with endometrial hyperplasia without atypia, who was treated medically, and the first sample come regression, and we stop the medical treatment for her. How we can follow up? We can follow up this lady by endometrial sample according to the risk factor for her, and I will discuss this in the next slide. If the endometrial biopsy came, it is persistence of the disease. What is the management? Management will depend on the type of hyperplasia. If the endometrial hyperplasia was without atypia, we can start medical treatment of observational treatment failed. And we can advise total hysterectomy plus or minus bilateral salpingo-oophorectomy if the bleeding persists or if the hyperplasia persists after 12 months of medical treatment. Again, if the hyperplasia persists after 12 months of medical treatment, offer total hysterectomy plus or minus bilateral salpingo-oophorectomy. So persistence here for the endometrial hyperplasia without atypia. If the initial biopsy was endometrial hyperplasia with atypia, and the second biopsy came after 3 months from the initial treatment, confirm persistence of endometrial hyperplasia with atypia, advise total hysterectomy plus bilateral salpingo-oophorectomy. So, the management of persistent hyperplasia will be Advice for total hysterectomy, bilateral salpingio-oophorectomy in case of endometrial hyperplasia with atypia. And in case of endometrial hyperplasia without atypia, if no medical treatment, start medical treatment. And if it's still persistent after 1 year of medical treatment, offer hysterectomy plus bilateral salpingio-oophorectomy. What about the management of progression? Means we give treatment for endometrial hyperplasia without atypia, and the result after 6 months come, it is endometrial hyperplasia with atypia or endometrial cancer. Review the treatment. If endometrial hyperplasia, we will do total hysterectomy plus bilateral salpingio-oophorectomy, total hysterectomy plus or minus bilateral salpingio-oophorectomy. And if the result was endometrial cancer, management according to the local cancer guideline. In both cases, when we do hysterectomy for persistent sample after management or for progression, what is the follow-up? The follow-up, arrange follow-up. If the hysterectomy sample came no endometrial cancer, review at 6 weeks and discharge. If the hysterectomy sample came endometrial cancer, management according to the local cancer guideline. So after we do hysterectomy, either for persistent hyperplasia or for progression of hyperplasia, we will review the histopathology of the removed uterus. Is there any endometrial cancer? No. So we can discharge the patient after 6 weeks. If endometrial cancer, management according to the local cancer guideline. In the next slide, I will go back for the patient who hair biopsy show regression, and we offer the hair to stop the oral progesterone after 6 weeks or can continue on Mirena coil for 5 years. How we can follow up this patient later on? This is the next slide. So next slide, we will move to the algorithm of regression. So in regression, we can review the treatment. If the patient is happy about Mirena and there is no fertility issue, we can continue for 5 years. If the patient was treated with oral progesterone and the sample came regression, we can stop after 6 months. If it's still symptomatic, we can offer total hysterectomy plus or minus bilateral salpingio-oophorectomy. How we can follow up the lady who opt for non-surgical treatment? So we will arrange follow-up according to the risk for hyperplasia and cancer. If it was endometrial hyperplasia without atypia and the body mass index less than 35, at least we need 2 or more consecutive negative endometrial biopsy at 6 months interval, then discharge. So we'll offer the patient to do outpatient endometrial biopsy in proper way, 6 months interval, at least 2 negative. If the 2 negative come and the body mass index of the patient less than 35, we can discharge the patient later on. And of course, advise here, if recurrent bleeding, we must re-evaluate to exclude relapse. If the body mass index equal to or more than 35, or the patient treated with oral progesterone, we need at least 2 consecutive negative endometrial biopsy at 6 months interval. After that, discharge, no, annual endometrial biopsy and review. So we'll do annual endometrial biopsy and follow up because she is high risk for relapse. If the management for endometrial hyperplasia with atypia, we need more than 2 consecutive negative samples, at least 3 months interval, and thereafter 6-12 monthly endometrial biopsy and review. So, if the management for endometrial hyperplasia with atypia, we need at least 2 consecutive negative endometrial biopsy at 3 months interval. After that, 6 months interval. After this 12 months interval, endometrial biopsy and review. If any relapse for that, what we will do, advise total hysterectomy and bilateral salpingo-oophorectomy, or advise total hysterectomy plus or minus bilateral salpingo-oophorectomy according to clinical evaluation. What is the place of hysterectomy in patient with endometrial hyperplasia without atypia? When can we do or offer hysterectomy for a patient with endometrial hyperplasia without atypia? Hysterectomy is indicated in women not wanting to preserve their fertility and has endometrial hyperplasia without atypia when progression to atypical hyperplasia occurs during follow-up, no histological regression of hyperplasia despite 12 months of treatment. No regression in spite 12 months of treatment. There is relapse of endometrial hyperplasia after completing progesterone treatment. There is relapse of endometrial hyperplasia after completing progesterone treatment. There is persistence of bleeding symptoms. There is persistence of bleeding symptoms. Or the woman declines to undergo endometrial surveillance or comply with medical treatment. So this is the indication of hysterectomy in case of endometrial hyperplasia without atypia in women not wanting to preserve their fertility according to Royal College of Obstetrician and Gynecologists. We will speak now about highly specialized area, which is management of endometrial hyperplasia and endometrial cancer in patients who want to get pregnant, endometrial hyperplasia and fertility. My speak will be basic overview, but the details of this topic must be taken from expert in this field. In general, the candidate patient for fertility-sparing treatment must undergo disease regression, treated by fertility specialist till pregnancy occur, usually through ART, assisted reproductive technology, and once pregnancy and delivery happened, surgical treatment in the form of hysterectomy plus or minus bilateral salpingo-oophorectomy must be done. The details of this topic I will explain in the few coming lecture and few coming slides. Again, it is a basic overview, and the details of this topic must be taken from expert in this field. Fertility-sparing treatment in endometrial hyperplasia and in endometrial cancer. In the coming few slides, we will cover 4 items which are considered essential for fertility-sparing treatment. The first item, the conditions and the patient selection and the counsel for fertility-sparing treatment. The second item about the pre-therapeutic workup, how we can be sure that no myometrial invasion and no ovarian malignancy. The third item about our certainty of endometrial hyperplasia or endometrioid stage 1A grade 1 endometrial cancer. The fourth item, how we can confirm our diagnosis. After that, we will speak about the algorithm of management and follow-up. Conditions for fertility-sparing treatment in young women with endometrial hyperplasia, atypical one, or early endometrial cancer. Patient with atypical endometrial hyperplasia or early stage endometrial cancer. Early stage means stage 1A, grade 1, endometrial cancer with no myometrial invasion and without genetic risk factor. Again, patients who are candidate for fertility preserving treatment must be referred to a specialist center. Fertility-sparing treatment should be considered only in patients with atypical endometrial hyperplasia or grade 1 endometrial carcinoma without myometrial invasion and without genetic risk factors. No evidence of infertility because the target to postpone the surgical treatment is to get pregnant. So, condition of no evidence of infertility. Patient and her partner must have a strong desire of pregnancy and or fertility preservation. Patient must accept adequate hormonal treatment. Patient must accept adequate hormonal treatment. Compliance to a close surveillance up to pregnancy. Compliance to close surveillance up to pregnancy. Accept completion hysterectomy. Patient must be aware that fertility-sparing treatment, it is not the treatment of endometrial hyperplasia with atypia and not the treatment of stage 1A grade 1 endometrial cancer. The treatment is hysterectomy. And she must accept the completion hysterectomy once she deliver her baby or in case of failure of treatment, either with no pregnancy or no response to the treatment. Fertility-sparing treatment. What is the pre-therapeutic workup? Indeed, the pre-therapeutic workup has two essential goals. The first one, to confirm that there is no myometrial invasion. To confirm that there is no myometrial invasion. The second thing, to confirm that no ovarian malignancy. No ovarian malignancy. Or we can say that to confirm the high probability of no extrauterine disease, particularly in the ovaries. To confirm that high probability of no extrauterine disease, particularly ovarian malignancy. Regarding exclusion of myometrial invasion, the expert transvaginal ultrasound done by expert or by MRI. Indeed, radiological imaging to assess the extension of the disease must be performed by an expert ultrasound examination, and expert ultrasound examination can substitute pelvic MRI. Again, expert ultrasound examination can substitute pelvic MRI scan. Regarding confirm the probability of no extrauterine malignancy or extrauterine extension of the disease or exclusion of ovarian malignancy, what we can do? We can do either MRI, and if there is any doubt, MRI can be supported with laparoscopy. Third aspect in fertility-sparing treatment is the certainty of endometrial hyperplasia or endometrioid stage 1A grade 1 endometrial cancer. How we can be certain about that? Through endometrial biopsy. The guideline mentioned that hysteroscopic biopsy is suggested based on its higher agreement with the final diagnosis compared with dilatation and curettage. So, we can assess the endometrial pathology through hysteroscopic biopsy, and I need to mention here that hysteroscopic endometrial resection under general anesthesia can be done. Removal of the endometrium and the superficial layer of myometrium, so you are sure that all the affected area of endometrium is removed and there is no evidence of invasion of myometrium. But hysteroscopic endometrial resection has impact on the fertility and the course of pregnancy, as we will mention later on. The other option is to do D and C. The guideline stated that hysteroscopic biopsy is suggested to be the method of choice in comparison to the D and C. Also, we need to mention that hysteroscopic endometrial resection under general anesthesia or blind dilatation and curettage is superior than the office aspiration biopsy. The fourth item in fertility sparing treatment is the pathological assessment of the curettage. It is crucial, it is very important that the curettage must be assessed by at least 2 expert pathologists to confirm the diagnosis and to confirm the grading of the tumor, and as a prognostic factor, they can detect presence or absence of progesterone receptor. But detection of progesterone receptor, it is not a routine practice, but it is essential to be sure about diagnosis and grading for the endometrial curettage. To summarize, it is important to be treated by highly specialized center, proper patient selection and counseling, must work in the pre-therapeutic workup as we mentioned before, and you must confirm the diagnosis, and the histopathology must be interpreted by 2 or more expert pathologists. The next step is the general assessment of the patient as a general status and fertility assessment, and after this we'll start the treatment and follow-up. We will discuss this in the following slides. Now it is the time to assess the patient general status and fertility assessment. As you know, obesity can affect fertility, and it plays a role in the development of endometrial hyperplasia. So, for fertility purpose, optimizing body weight is essential. But what about the relation between obesity and survival rate in case of endometrial cancer? Indeed, the current guideline mentioned the following. There is currently a lack of high-quality evidence regarding the correlation between weight loss and the reduction of risk of recurrence or increased survival in patients with endometrial carcinoma, especially with respect to fertility-sparing treatment. Again, there is currently a lack of high-quality evidence regarding the correlation between weight loss and reduction of risk of recurrence and increased survival in patients with endometrial carcinoma, especially with respect to fertility-sparing treatment. What about diabetes mellitus? Guideline mentioned diabetes mellitus doesn't seem to affect the outcome of conservative treatment in women with atypical hyperplasia or early endometrial carcinoma. Diabetes mellitus doesn't seem to affect the outcome of conservative treatment in women with endometrial hyperplasia or early endometrial carcinoma. Conversely, the use of metformin seems associated with an improvement in overall survival for patients with endometrial carcinoma and a reduced risk of cancer relapse. In addition, metformin is associated with improvement in the overall survival of patients with endometrial carcinoma with diabetes. This is the guideline 2020 endometrial cancer management. So the summary: obesity for fertility, correction of obesity is important. For endometrial cancer, regression, survival, relapse, the use of metformin is important. Also, it is important to assess the couple for factors of infertility. Fertility-sparing treatment aiming to get pregnant and after delivery to go for surgical treatment. So the factor for infertility must be evaluated by a specialist consultation in fertility field. Take in consideration the patient age, the couple status, their desire for fertility, history of pregnancy before, the need for ART or assisted reproductive technology to get pregnant. All of this must be evaluated and discussed with the couples before starting the treatment and after starting the treatment, and all this evaluation must be done by specialized consultation from fertility expert. Fertility-sparing treatment patient information. Patient must be informed clearly, deeply about the principle of treatment from a specialized tumor board. So the management principle must come from a specialized tumor board, from experts in this field. It is not for the practice of junior doctors or general gynecologist or obstetrician. It must come from a specialized tumor board. All the principle of treatment and the surveillance must come from a specialized tumor board. The progesterone therapy is a temporary fertility-sparing treatment. The patient must understand that the progesterone therapy is not a final treatment. It is a temporary treatment till she gets pregnant. After this, go for radical treatment, which is the surgical treatment or hysterectomy. Total hysterectomy, laparoscopic or abdominal, plus or minus bilateral salpingo-oophorectomy is the treatment and must be done after pregnancies as soon as possible. Close surveillance during treatment is necessary in a reference center. Repeat, MRI, curettage, reference pathologist, again, reference center, and close surveillance is mandatory. And the patient must be aware about and informed about that. ART, assisted reproductive technology, is often advocated to improve fertility results. A change of lifestyle, weight loss, diabetes management, metformin, patient must be given clear information about all of that. Now I will discuss about the algorithm for management and which management: hormonal treatment, oral progesterone, levonorgestrel intrauterine device, or endometrial resection plus or minus progesterone therapy. Let us to start. Young patient with atypical endometrial hyperplasia or endometrial cancer stage 1A grade 1, as we mentioned, must be referred to a specialized for plan of management in case of fertility-sparing treatment. And endometrial biopsy can be done either with hysteroscopic resection or D&C, and the curettage must be seen by 2 or more expert pathologists, in addition to expert ultrasound for evaluation of endometrium and excluding myometrial invasion, or with MRI, and counseling the patient by fertility specialist team before and after starting the treatment. So this is the first step of algorithm. So patient with atypical endometrial hyperplasia or grade 1 stage 1 endometrial cancer candidate for fertility-sparing treatment can receive the treatment in the form of hormonal treatment. The hormonal treatment may be medroxyprogesterone acetate 400 to 600 mg per day or megestrol acetate 160 to 320 mg per day. And this is the recommended treatment. Medroxyprogesterone acetate or megestrol acetate is the recommended treatment by the guideline for management of endometrial cancer. However, treatment with levonorgestrel intrauterine device in combination with oral progesterone with or without gonadotropin releasing hormone analog can also be considered. So, the recommended is medroxyprogesterone acetate or megestrol, but we can use levonorgestrel intrauterine device, Mirena, plus oral progesterone plus or minus gonadotropin releasing hormone. After treatment, the follow-up. In order to assess the response, we need follow-up within 3 to 4 months and after 6 months, as we mentioned later on. Follow-up. In order to assess the response, hysteroscopic guided biopsy, dilatation and curettage, and expert ultrasound or MRI must be done 3 to 4 months and after 6 months from the treatment. If there is complete clinical response with the medication and the patient get pregnant or conception and the fertility plan completed, we will go for the definite treatment is hysterectomy plus or minus bilateral salpingio-oophorectomy. If complete clinical response happened and the patient opted to defer the pregnancy, she didn't need to get pregnant now, in the presence of complete clinical response to the treatment, maintenance therapy with progesterone can continue plus the follow-up. Strict surveillance is recommended every 6 months with transvaginal ultrasound and physical examination. During follow-up, hysteroscopic and endometrial biopsy should be performed only in case of abnormal uterine bleeding or atypical ultrasound finding. So, strict surveillance is recommended every 6 months with transvaginal ultrasound and physical examination. During follow-up, hysteroscopic and endometrial biopsy should be performed only in case of abnormal uterine bleeding or atypical ultrasound finding. This is the recommendation of the guideline. Okay. After initial treatment, and we did D&C hysteroscope, ultrasound 3 to 4 months after start treatment, and 6 months again after start treatment, and there is partial clinical response. What we will do? We can continue the hormonal treatment and re-evaluate after 6 months from initial treatment by hysteroscopy, expert ultrasound or MRI, and dilatation and curettage to see what will happen. If partial or persistent disease, we must go for surgical treatment, surgical hysterectomy plus bilateral salpingio-oophorectomy. If the patient was given the treatment and after 3 to 4 months and after 6 months, D&C and the hysteroscope and the ultrasound confirmed no response, so the management from the start is hysterectomy plus or minus bilateral salpingio-oophorectomy, and in this case, fertility sparing treatment was failed. And this plan of management must be clear to the patient, must be tailored by highly specialist center. Surveillance must be done by highly specialist center. It is important to mention that fertility sparing treatment can be considered for intrauterine recurrence only in highly selected cases under strict surveillance. Hysterectomy and bilateral salpingio-oophorectomy is recommended after childbearing due to high recurrence rate. Preservation of the ovaries can be considered depending on the age and genetic risk factors. This is the statement of the guideline for management of endometrial cancer 2020. Discussed hormonal treatment as a method of fertility sparing treatment in endometrial hyperplasia and early stage endometrial cancer. There is another method of treatment called hysteroscopic endometrial resection under general anesthesia plus progesterone. It involves removal of endometrium and the superficial layer of myometrium under general anesthesia. The advantages of this method: complete removal of all the lesion, leaving minimal residual tissue to the effect of progesterone later on. Meta-analysis, in spite of a small number of patients, showed high regression rate of hysteroscopic endometrial resection. But this method have disadvantages regarding obstetric outcome, so caution must be observed and practiced during the deepness of resection. The disadvantages include first trimester miscarriage, preterm delivery, premature rupture of membrane, and abnormal placentation. Management of endometrial hyperplasia in patients using HRT or hormonal replacement therapy. Before I mention the management, I need only to mention something. If we suspect lady on HRT to have endometrial hyperplasia and we need to take endometrial sample from it, what about the continuation of HRT prior to investigation? The question to stop the HRT, then send the patient to take biopsy, or let the patient to take HRT and take the biopsy while the patient in HRT. According to the Irish guideline, they mentioned that use of sequential HRT generally lead to thickening of the endometrial lining, whereas continuous combined HRT and tibolone cause endometrial atrophy. There is uncertainty as to whether HRT should be stopped or not prior to investigation for postmenopausal bleeding. There is unlikely to be any problem in histological interpretation if the woman remains on HRT, provided the pathologist is given details of hormonal treatment. In addition, the pathologist may be able to identify a change in the endometrium that are hormonally induced and could explain the abnormal or unscheduled bleeding. Alternatively, by stopping the HRT and inducing an estrogen withdrawal bleeding, tissue may be theoretically be lost that should be assessed. So the Irish guideline recommend or support to continue on HRT and send the patient to take endometrial biopsy. But I need to mention something. In Western area, the time of referral for patient to take biopsy or to evaluate malignancy, it is called the urgent one. Means time from you suspect a problem to sending for biopsy, it must be less than 2 weeks. So it is relatively short time. They didn't send the patient for biopsy and the biopsy will be taken after 1 year. No, it must be according to a strict time frame. I think within 2 weeks. This is very important to be observed in developing countries. The second part, what about the management of endometrial hyperplasia in patient receiving HRT? The Royal College of Obstetrician and the Gynecologist mentioned that systemic estrogen alone is not indicated or not allowed. So no estrogen alone to be used in a woman with a uterus. Sequential HRT, if the patient on sequential HRT and developed the endometrial biopsy and developed the endometrial hyperplasia, it changed to continuous progesterone, mainly levonorgestrel intrauterine device. So women with endometrial hyperplasia taking a sequential HRT preparation who wish to continue HRT should be advised to change to continuous progesterone intake using levonorgestrel intrauterine device or continuous combined HRT preparation. Subsequent management should be as described in the preceding algorithm I mentioned before. If the patient or women with endometrial hyperplasia taking a continuous combined preparation who wish to continue HRT should have their need to continue HRT reviewed. We must review it is indicated to continue this medication or no. Discuss the limitation of available evidence regarding the optional progesterone regimen in this context. Consider using levonorgestrel as a source of progesterone replacement. Subsequent management should be as described in the algorithm mentioned before. So, no estrogen alone in the presence of uterus. Sequential HRT and the patient need to continue HRT, we can move to continuous progesterone, mainly levonorgestrel. If the patient was using continuous combined HRT, we must review the indication for HRT and if the patient actually in need or no. We must counsel the patient on proper way. We must offer for her to use levonorgestrel intrauterine devices as a source of progesterone replacement, and in all cases we must follow up the algorithm or the guideline of management of endometrial hyperplasia. Management of endometrial hyperplasia and tamoxifen in case of breast cancer. How should women who develop endometrial hyperplasia while on tamoxifen treatment for breast cancer can be managed? The need for tamoxifen should be reassessed and management should be according to histological classification of endometrial hyperplasia and in conjunction with the woman's oncologist. There is evidence that levonorgestrel intrauterine device prevents polyp formation and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. But the effect of levonorgestrel intrauterine device on the breast cancer recurrence risk remain uncertain. The effect of levonorgestrel intrauterine system on the breast cancer recurrence risk remain uncertain. So its routine use can't be recommended. So we can't recommend the routine use of Mirena coil in patients with history of breast cancer under tamoxifen treatment as a prophylactic from endometrial hyperplasia. The Royal College mentioned that the need for tamoxifen should be assessed and managed according to the histological classification of endometrial hyperplasia. The opinion of the oncologist must be priority. How should endometrial hyperplasia confined to an endometrial polyp be managed? Complete removal of the uterine polyps is recommended and an endometrial biopsy should be obtained to sample the background endometrium. Complete removal of the uterine polyps is recommended and an endometrial biopsy should be obtained to sample the background endometrium. Subsequent management should be according to histological classification of endometrial hyperplasia. Finally, take work message about importance of addressing the increased body mass index. Increased body mass index has negative impact on the general health as a whole and increase the risk of hyperplasia and endometrial cancer. Levonorgestrel intrauterine systems is effective and convenient method for management of endometrial hyperplasia without atypia, and it is easily to be inserted by the general practitioner or the family health doctors. Also, it is very important to highlight the importance of ambulatory gynecological clinic or one-stop clinic, where it is one room represents a clinic through which you can do trans-abdominal, transvaginal scan, you can do outpatient office hysteroscopy, even you can remove a small polyp or small fibroid less than 2 centimeters with either mechanical hysteroscopic morcellators, and you can take outpatient endometrial biopsy with Pipel device, and you can insert levonorgestrel intrauterine device. You can take also the pap smear and endocervical biopsy. This is in one clinic, in one room. So the waiting list for routine gynecological clinic will be decreased, and the rapid review for the patient and the policy of see and treat will be implemented. In my lecture, I introduced only simple, basic overview for management of endometrial hyperplasia, according to the available up-to-date guideline in front of me. But as you know, every day there is new thing in the guidelines, and it is the responsibility for every physician to keep himself updated about the new guideline, so the management plan can be changed. What is evidence-based today can be modified tomorrow. So I think it is very important to keep updated. After a few months, these lectures may be out of up-to-date and they need to be updated, and this is the responsibility for everyone. One guideline is very important, I need to highlight it, which was published in the International Journal of Gynecological Cancer. The title is Guideline for Management of Patients with Endometrial Carcinoma. This guideline represents the group outlined by European Society of Gynecological Oncology, ESGO, the European Society for Radiology and Oncology, ESTRO, and the European Society for Pathology, ESCP, jointly described the up-to-date this evidence-based guideline and to cover new topic about the management of endometrial carcinoma, and it is important for every physician to have a look for this guideline. Finally, this is the sources for my lecture, Management of Endometrial Hyperplasia Top Guidelines, Investigation of Postmenopausal Bleeding Guideline, Irish Guideline, American College of Obstetrician and Gynecologist Committee Opinion, the role of transvaginal ultrasonography in evaluation the endometrium of women with postmenopausal bleeding, and the committee opinion about endometrial hyperplasia, the up-to-date, and the guideline for management of patients with endometrial carcinoma, International Journal of Gynecological Cancer. I hope it will be beneficial for you. I will be happy to receive your feedback about the lecture, the negative feedback before the positive feedback. The lecture will be available in the YouTube channel created by my daughter. Would you please only to use your mobile to scan the code, barcode on the left hand side, and you will be taken directly to the YouTube website for my channel. Your feedback will help me for more improvement. So I am waiting for your subscribing in the channel and for your kind feedback. Thanks very much for your audience and for your time. Indeed, I need to thank and remember my father, my mother, asking Allah to give paradise for them. I would like to ask my wife because she do her best to design this lecture by herself. I would like to ask my daughter Lara because she helped me deeply to put the final design for the lecture. Thank you very much. وأسألكم إن كان في هذه المحاضرة خيرا الدعوة إلى والدي رحمة الله عليهما والدعوة إلى وأموات المسلمين أجمعين. اللهم اجعل الجنة مثواهم. Thank you very much. Thanks very much.
Thank you and stay safe, Lara. Goodbye.